Good morning, everyone. This is a subject that may be unfamiliar to some of you, but which is something that over the last several years I've become very passionate about. It's a way of providing passive immunity to the gastrointestinal tract by utilizing the global experience of the immune response in cows to human health and disease. And it's a subject that began in veterinary medicine. And I'm going to spend some time talking about the subject in general and go through some clinical experience that we've had. In the U.S., this product is considered a medical food. And a medical food is a regulatory category that was established by the Federal Drug Administration, the FDA in the U.S. in 1988 with the passage of the Orphan Drug Act. And it is a product that is regulated to be a product of nutritive value in the management under a physician's direction for a chronic medical disorder. And medical foods have been used since the 1940s. They were initially used as nutritional supplements. The first significant advance in the medical food area was in the 1950s with infant formula for children with PKU, removing phenylalanine from infant formula. And there are now large numbers of medical foods available. All of the tube feedings that we use, for example, in patients who have percutaneous gastrostomies or nasogastric food feedings are classified as medical foods. These are an example of several medical foods that are available. Even probiotics like VSL number 3 are medical foods. And of course, the nutritional support and tube feeding formulas that we've discussed. This slide looks at what the issues are in the U.S. in terms of regulation. Medical foods are designed to manage a chronic condition. They require safety. They have to be approved by toxicology experts. And their efficacy has to be demonstrated by clinical studies. Very different than dietary supplements and similar to FDA-approved drugs. The differences are that medical foods are generally recognized as safe and do not have to undergo high levels of safety testing. So why should we think about bovine-derived immunoglobulin? We'll talk a little bit about the history of administering immunoglobulins both intravenously and orally in human health and disease. But obviously, colostrum and breastfeedings help establish the health of the gastrointestinal tract and mammalian systems. And by administering bovine-derived serum immunoglobulin, we can provide passive immunity to help reduce inflammation in the intestinal tract. Familiar immunoglobulin therapy includes the use of IVIG in a variety of therapies, and monoclonal antibodies, which we widely use in the treatment of autoimmune diseases, including inflammatory bowel diseases, ankylosing spondylitis, rheumatoid arthritis, psoriatic arthritis, and other chronic inflammatory diseases. Oral immunoglobulins have been used in a variety of infections, particularly gastrointestinal infections, ranging from cryptosporidiosis to enterotoxigenic E. coli, shigellosis, necrotizing enterocolitis, and cholera. And a variety of diarrheal diseases have been successfully treated with orally administered immunoglobulins as well. And we're going to talk a little bit about some clinical studies that have been published over the last several years since bovine-derived serum immunoglobulin have become commercially available. One of the important things to first think about is if we administer immunoglobulins orally, do they survive the gastrointestinal tract? Do they pass through the aggressive digestive system that occurs? Orally administered immunoglobulin of bovine and other sources can be, in fact, recovered from the stool. And as I mentioned, this is an interesting story that began in the pork industry. As agribusiness has begun to dominate the food supply, there have been changes in the way animals are brought to market. And in the U.S. and in Canada, particularly, this was true in the pork industry, where piglets were prematurely weaned from sows and were put into feeding pens. They were deprived of colostrum early in their life and developed a significant incidence of enterocolitis, which was fatal in 10% of the cases. And if plasmid proteins were added to the piglet feed, it virtually eliminated the incidence of enterocolitis and was obviously of great economic benefit, and demonstrated the ability to increase lean body mass, improved oral intake of food, protein utilization, and at the present time, 85% of swine production in the U.S. and 65% in Europe benefit from the addition of serum bovine-derived immunoglobulin. So this product, Interrogam, serum bovine-derived immunoglobulin, is pooled at production from 3,000 cows to maintain homogeneity and reproducibility. As I mentioned, they contain the total immune experience of cows. Cows, of course, feed in pastures and are exposed not just to the nutritive value of the pastures, but to the fecal residue of other cows in the herd. And so consequently, they have high levels of antibodies in their serum to a variety of microorganisms and enterotoxins. SBI contains mostly IgG, small amounts of IgA, which raises some very interesting issues about immunodeficiency disorders, and IgM. It also contains other proteins and albumin, including proteins that are similar to those found in colostrum. So how would this work? How would administering immunoglobulin into the lumen of the gastrointestinal tract be of potential benefit? Each individual has genetic factors, individual predisposing factors that may or may not allow the expression of disease upon intraluminal insult. And then all of us are exposed to environmental factors, whether it's infection, medications, immunocompromising medications, corticosteroids, long-term administration of PPIs, periodic antibiotic uses, which alter the microbiome, intercurrent viral gastrointestinal infection, or food poisoning. These can result in alteration of the gut microbiota. This can lead to intestinal inflammation at the gut mucosal interface, interfere with gut barrier function, the so-called leaky gut, and impaired nutritive absorption in the enterocytes themselves. And that, of course, can lead ultimately to changes in bowel function, the development of loose or frequent stools, urgency to defecate, abdominal discomfort, pain, and abdominal bloating. Our concept is that serum bovine immunoglobulin binds to intestinal microbial components in the lumen that ultimately reduces mucosal inflammation and improves tight junction function between enterocytes and reduces intestinal inflammation. And so we can see that we have this concept of enteropathy, of diffuse intestinal dysfunction that occurs in a variety of disease states that range from diarrhea-predominant irritable bowel syndrome to inflammatory bowel disease to acute and chronic intestinal infection. And SBI can bind microbial components. It maintains immune balance at the gut luminal interface. It manages gut barrier function, and it improves nutrient utilization in immunocompromised individuals, as we'll demonstrate. It actually can reduce fecal nitrogen loss, improve D-xylose testing, and reduce diarrhea. So we have a mechanism by administering immunoglobulins, which are obviously very safe to the gastrointestinal tract, we can actually alter gastrointestinal function. And I think that this is going to be very interesting because Dr. Hermosa is going to present a paper at the end of this session talking about about a specific inflammatory mediator that influences inflammatory bowel disease. And this is sort of a clinical overview of why that kind of very fine biochemical detail may be very important in the management of a variety of disease states. There have been a number of publications looking at diarrhea predominant irritable bowel syndrome, obviously a very common clinical problem. Potentially 20% of the population in most Western societies have irritable bowel syndrome, and diarrhea predominant irritable bowel is perhaps the most difficult to manage clinical problem in this group of patients. This particular paper is the first randomized double-blind controlled study to look at SBI in managing patients with irritable bowel syndrome. It looked at a quality of life score, looking at 36 patient-reported outcomes in patients who were treated with high dose, low dose, or placebo SBI for treating irritable bowel symptoms. Patients were screened and then administered drug versus placebo at baseline, and clinical diaries were looked at 2 weeks and 4 weeks. And the endpoint at the end of 6 weeks of study was the number of days per week where there was an improvement in symptoms. And we can see from the results that those patients with high-dose SBI, 5 grams BID, had dramatic effects that were statistically significant in all patient reported complaints, from any symptom to urgency and loose stools. Those patients who were treated with low dose, 5 grams of product plus 5 grams of placebo, had an intermediary response. And those patients who were treated with placebo alone had really no change in their treatment, and they had no change in their outcome that was measurable statistically. This is a theme that we'll repeat through the course of this presentation. There were no serious adverse events reported, and withdrawals from the study due to adverse events were equivalent and minor in both the drug and the placebo-treated group. We also have a number of retrospective studies that have been published looking at patients with refractory irritable bowel syndrome. This is a retrospective report of 10 patients treated with refractory irritable bowel syndrome who did not improve on conventional therapy. 9 of the 10 patients in this study were female. In North America, at least, the preponderance of patients with irritable bowel are female. The average age was 58. People in this study met the Rome 3 criteria and reported either a 0 to 25% improvement in their symptoms, a 25 to 50% improvement of their symptoms, a 50 to 75% improvement in their symptoms, or 75 to 100% improvement in their symptoms. And as you could see, patients did in fact, by and large, improve. 5 of the 10 patients had a 50 to 75% improvement of their symptoms, and the other 5 had reported a 75 to 100% improvement in their symptoms. So the onset of symptom improvement generally occurred within 2 to 4 weeks. We see this as a recurring theme with the administration of SBI. It takes about 2 weeks for it to be clinically effective, and we think that occurs because we're changing some intraluminal events. The patients demonstrated significant improvements, and there were no significant adverse reaction. A similar study was done in patients with irritable bowel syndrome, trying to stratify the patients with irritable bowel as to whether lactulose breath testing was important in predicting outcome, and that obviously was designed to look at whether the microbiome was influential in determining outcome. The response rate to the inclusion of SBI was calculated in 3 separate groups, depending upon their lactulose breath tests, depending upon whether they were diarrhea-predominant irritable bowel or mixed irritable bowel, and then looking at all patients together. So patients were stratified as to whether their lactulose breath tests were positive or negative. Those patients who had a positive lactulose breath test were treated with rifaximin. If they were still unresponsive, they then went on to be combined with people with traditional therapy and were treated with 5 grams of SBI BID for 4 weeks. We can see that whether the patients had IBS-M or IBS-D, there was a robust response in terms of patient-reported outcome, but there was no significant difference based upon whether or not their lactulose breath testing were positive or negative. Adverse events occurred in only 3 of 24 patients, and again, SBI appeared to be a safe and effective nutritional treatment in refractory IBS-D and mixed IBS patients. This is a study that I was involved in that was recently accepted by the World Journal of Gastroenterology. We looked at 14 irritable bowel patients who received serum bovine immunoglobulin as add-on therapy. 2 were patients with IBS-C, 7 were patients with diarrhea-predominant irritable bowel, 2 with mixed alternating diarrhea and constipation, and 3 with undefined irritable bowel symptoms. And they were treated with either 5 or 10 grams of SBI a day. And overall, 12 of the 14 patients indicated some level of improvement. This is a review of the diarrhea-predominant irritable bowel syndrome. You can see that they are a relatively representative group. Some were treated with anticholinergics. Some were treated with antidiarrheals. Many of the patients were on a low FODMAP diet. The constipation-predominant patients had constipation, bloating, distension, and nausea. As a general rule, the constipation-predominant patients did not respond to treatment with SBI. There was a modest response in the mixed patients and some improvement in the unclassified irritable bowel patients. So what we see in summary among patients with irritable bowel syndrome, it is the diarrhea-predominant irritable bowel group that seemed to benefit most from management of their symptoms with SBI. That makes a great deal of sense to me physiologically because our belief set is that there is a low level of inflammation at the gut mucosal interface among patients with diarrhea-predominant irritable bowel, and that there's probably a spectrum between diarrhea-predominant irritable bowel syndrome and inflammatory bowel disease. It's a very intriguing concept that I'd like to open for discussion when I finish my presentation. Inflammatory bowel disease obviously is a much more challenging area with much greater import in terms of significant morbidity to patients. This first paper is a single retrospective chart analysis of 45 patients with inflammatory bowel disease with 5 grams of serum bovine immunoglobulin added to conventional therapy, and a multivariate logistical regression model was used to see whether patients reported improvement in their clinical symptoms. And we can see that the average patient response went from minimal to more than moderate with a regression analysis of the data reported by patients. The odds ratio was 2.75, that patients were more likely to report improvement in clinical symptoms when SBI was added. Therefore, this is a good tool for managing patients with inflammatory bowel disease. And of course, the next step is to look at whether we have other more robust reports of how patients respond, leading up to ultimately whether or not there's endoscopic improvement in patients with inflammatory bowel disease who are treated with SBI. This is a retrospective review of 7 patients that I have published, and I chose in this case report patients with Crohn's disease and ulcerative colitis who represented very specific clinical problems that all of us face. And we looked at their individual responses. Each patient that I selected was a paradigm for common patients who are difficult to manage, and is really set. And this analysis set the stage for a randomized double-blind controlled trial that we're about to begin in the first quarter of 2016, using SBI versus placebo, and among other things, looking at fecal lactoferrin as a measure of ongoing inflammation. So among the Crohn's disease patients, we had a patient who had a total proctocolectomy and had high ileostomy output with typical complications of high ileostomy output, including renal stones, hypomagnesemia, elevated creatinine, and chronic dehydration. Two patients who had undergone remote hemicolectomy and required up-escalation of their therapy, and a young man with nutritional failure and weight loss despite aggressive medical management. The ulcerative colitis patients also represented typical difficult-to-manage patients, a patient who presented with pancolitis unresponsive to conventional therapy, a patient who had a total proctocolectomy for refractory disease and now had pouchitis, and we have a lot of experience evolving with pouchitis, and a patient with sudden onset ulcerative proctitis who did not respond to conventional therapy. And as we all know, these are challenging patients because we often up-escalate their treatment and have the danger of making our treatment far more aggressive and worse than their underlying disease. And we demonstrated that all patients in this group responded clinically to the addition of SBI to their regimen. The ulcerative colitis patients reported resolution of symptoms such as rectal bleeding, urgency, and/or nocturnal incontinence. For the Crohn's disease patients, outcomes included improvement in weight, reduction in other therapies, and normalizing their treatment, and a decrease in ileostomy output and improvement in creatinine and BUN levels. And again, this sets the stage for randomized controlled clinical trials for this regimen. This next patient is a patient who had longstanding pan-ulcerative colitis, who was maintained on adalimumab and developed a C. difficile infection after treatment of septic arthritis. The adalimumab was then, of course, withdrawn. The patient had an exacerbation of the ulcerative colitis, and 5 grams of SBI was added QID, followed by maintenance therapy QDay. And there was improvement in the ESR, reduction in the white blood cell count, improvement of the hemoglobin, and a reduction in the platelet count. And remarkably, we can see simultaneously an improvement in the mucosa, endoscopic healing, post-SBI therapy, which was maintained remission. So after 2 months, this patient improved clinically and had not only improvement in clinical symptoms, stool frequency, consistency, and a reduction in bleeding and cramping, but endoscopic improvement as well. This next patient is another patient reported from a center in Florida, a young man with pancolitis who failed to respond to repeated courses of steroids and maintenance therapy with oral and rectal mesalamine, who failed on antibiotics and monoclonal antibodies. 5 grams of SBI was added BID, and within 8 weeks there was an improvement clinically, as well again as an endoscopic improvement, and this was maintained for 1 year after administering SBI. The last part of the inflammatory bowel disease picture, which I think we should talk about, is something that all of us have become extremely sensitive to because we all are living in an era of diminished resources, and that is the pharmacoeconomic savings in inflammatory bowel disease. And this study was a retrospective chart data analysis in 21 patients with inflammatory bowel disease for whom SBI was added to their treatment, and it was looking at the improvement in their clinical symptoms and what the economic impact of that was. And the patients were managed with SBI for at least 8 weeks after they had begun therapy. And so there were 17 patients with Crohn's disease, 4 patients with ulcerative colitis, 62% were men. The mean age was 48. 4 people were over the age of 65. And you can see that these patients were on the various monoclonal antibodies, infliximab, vedolizumab, adalimumab, certolizumab, and they were divided into 3 groups: those people who were treated with biologics, those people who were not treated with biologics, people who were maintained on biologics, or who had not responded. The total savings was, in those people treated with SBI, was $376,000. Potential biologic costs saved by patients was $17,000, and if you added in the cost of SBI, the net savings per patient was $12,414 per year. We've also had the chance to look at fragile patient populations, patients who were at particular risk for serious complications, for refractory inflammatory processes in the intestine. This first patient is a patient of mine that was, the study was recently published in Clinical Medicine Insights Gastroenterology. It was an 84-year-old man with chronic mesenteric ischemia, progressive diarrhea, nocturnal diarrhea, fecal incontinence, abdominal pain, and nutritional failure. Within 1 month of 5 grams per day, there was a resolution of all symptoms and improvement in the patient's quality of life. This next study, and the last one I'm going to cite before we open up for questions, is patients with HIV-associated enteropathy. This is actually the first group of patients who were studied with serum bovine immunoglobulin, and this led to this product being fast-tracked by the FDA for clinical approval. The study was published in AIDS in 2012 and was a group of HIV-positive men with chronic HIV enteropathy despite aggressive treatment with retroviral therapy and otherwise having been stabilized. They were treated for 8 weeks. The patients who were treated for 8 weeks had a 66% improvement in the number of bowel movements per day. They had an improvement in the stool consistency scores with the Mertz stool scale, and a 53% improvement in their daily GI symptom scores. This was maintained through 48 weeks of treatment in terms of stool frequency and with the pictorial scale. And most remarkably, this is the only study that has demonstrated on duodenal biopsy after 8 weeks of treatment with SBI, reconstitution of gastrointestinal associated lymphoid tissue in the duodenum, which again suggests that we are having a salutary response on improving immune responsiveness. There were no adverse events reported in the study, no serious adverse events. And we also have some data in pediatric patients, but because we ran a little bit late, I'm going to stop here and open this up for discussion. Any questions or comments about this data? Yes, ma'am.
Thank you for the nice talk and a very exciting result. And I just would like to find out, so when you said the mechanism of action for the IgG in the intestine probably is binding to the bacteria and also can repair the mucosa or to have a tight junction, improve tight junction, etc. So I wonder if they bind to bacteria. What about the microflora, the balance? Is it?
Yes, so this is, we believe that this is ultimately going to be demonstrated as the mechanism of action. I presented a lot of material, and I moved very quickly through one of the mechanism of action slides, but we've demonstrated that serum bovine immunoglobulin combined with pro-inflammatory bacterial degradation products like lipopolysaccharides. It can combine with enterotoxin produced by a variety of microorganisms. It can combine with the A and B toxin produced by C. difficile colitis. In tissue culture models, we can demonstrate improved nitrogen absorption and integrity of the mucosal barrier and reduce lymphocyte populations in the submucosa. We are now looking at ribosomal RNA studies in the stool in patients in healthy controls and in patients with a variety of disease states who are treated with SBI. I believe that ultimately the mechanism of action will be a shift in the microbiome. My background prior to getting involved in this was to look at orally administered galacto-oligosaccharides, which were non-absorbable, and the effect that they had on the microbiome is basically as a nutrient source for non-inflammatory microorganisms in the gut, and we were able to demonstrate that one could increase the production of Faecalibacterium prausnitzii in the stool of patients who were healthy or who were ill by administering galacto-oligosaccharides. Faecalibacterium prausnitzii is absent in the stool of patients with Crohn's disease and is a pro-inflammatory microorganism. So we have a great deal of work to do to identify some of the precise changes, but we believe that ultimately that is exactly what we will identify, that there will be a salutary effect on the microbiome, and it's the evolution of ribosomal RNA studies on the stool that will allow us to demonstrate that. Is that an adequate response?
Yes, yes. I just want another question, sorry. Do you think they function locally and or they need to absorb into the bloodstream and come back to the colon to function? Because what I'm thinking is all this globin is a protein. So when you have to kind of digest into the amino acid, the small molecules. So by the time to reach to the colon, probably they all become amino acids.
Yeah, that's a very good point, and that was a source of great concern. Yeah. Most of the preliminary data with this product is from animal studies, and there are over 350 published studies in mammals, non-human mammals, that show anywhere between 10 and 40% of the molecule remains intact in the stool. We believe that the benefit really is in having the intact immunoglobulin molecule actually get into the colon. And then obviously once it gets into the colon, it probably is rapidly altered by the microbiome, either because it is adsorbed onto the surface of toxins or it is combining with pro-inflammatory cytokines or bacterial degradation products, so the ability to recover it intact in the stool. But the immunoglobulin does not undergo much digestion in the small intestine. And I did show a series of studies, and I apologize that I went through it quickly, that showed that there was substantial recovery of the intact immunoglobulin in the stool in both animals and human, regardless of whether the immunoglobulin that's administered is human immunoglobulin or other mammalian immunoglobulin. You're welcome.
Any other question to the presentation of Dr. Good? I have one question.
Yes.
Sorry. In relation to Dr. Liu questions, there's any chance to detect immunocomplex in the stool to see if these immunoglobulins can interact and sequester, for example, microbacterial metabolites or inflammatory molecules produced in the gut, like defensins that may alter this barrier function, as you present nicely at the beginning.
Yes, Dr. Hermosa, we actually are looking at this. Dr. Camilleri at the Mayo Clinic is actually doing a study in patients with C. difficile colitis and looking at the recovery of immunoglobulin with A and B toxin and other bacterial degradation products from the Clostridia organism. So we are anxiously awaiting that. I think that's a good model to use. Candidly, and Dr. Hermosa may be able to help us with this, we don't know exactly what to look at in terms of immunoglobulin binding in patients with inflammatory bowel disease. So, perhaps that could be something that you can shed some light on, and may be a source of good collaboration in the future. Yes, ma'am.
Sorry, it's too many questions.
No, that's wonderful.
So, and what about, you recommend to use SBI for remission, just prevent relapse, or you think it just manipulates better for the
our experience, that's a great question.
Yeah.
Our experience has been that we have maintained patients on serum bovine immunoglobulin for extended periods of time. I have patients with both diarrhea, predominant irritable bowel syndrome, and inflammatory bowel disease who we have maintained for 18 months and have seen, by and large, an improvement in the symptoms. Some of the IBD patients have had flares that have required intermittent therapy, but I would say 2/3 of the patients have had an improvement in the natural history of their illness. It's one of the reasons why I'm very excited about this randomized double-blind control study that we hope to start in 2016, because we'll actually be able to see the way the study is going to be structured is we're going to look at patients who are on active therapy with stable diagnoses, treat them with SBI versus placebo, and then follow them for 12 months and see if the SBI patients have fewer exacerbations. We're going to try to match the patients by the category of inflammatory bowel disease. In other words, same number of left-sided ulcerative colitis patients, pancreatitis patients, non-operative Crohn's disease patients, patients with Crohn's disease who have right hemicolectomy or ileal resection, and so on. And we'll see if by stratifying them we can see a benefit. That's clearly the next step that has to be looked at. Thank you very much.
Thank you, Professor Good, for your presentation.